Hi, everybody. Welcome to Noon Conference. Today we have a statistics conference. We won't be doing a lot of math, but I wanted to talk with you all more about ROC curves, as we've mentioned them a couple of times in our previous conferences, especially in the heart failure one. So I wanted to just dive into that a little bit and see how we can improve our clinical decision-making skills. So, a couple of announcements before we get started. Make sure to vote. Election day is November 3rd. So you still have a couple of days left to send in your ballot via mail. But now, getting closer to that date, it would be optimal if you dropped it off at a ballot box. There's a ballot box on the CU campus. Otherwise, check out whichever one you need to drop it off at in your county. And then in-person voting has already begun in Colorado, and so you can also go to the polls to vote there, and you can register same day. So it's a pretty streamlined process. And then the second thing is, if you are or aren't connected with our internal medicine Instagram, we have two contests going on right now. The first one is if you voted, so if more than 75% of the residents vote, then the Chiefs are gonna buy Santiago's burritos for everybody. And then the second contest is a Halloween contest. So send us your pictures of pumpkin carvings, your costumes that you're gonna hang out in at home. And the best ones will get a little treat bag for best pumpkin carving and costume. Okay, so let's get started. I wanted to just thank Dr. Amiran Baduashvili. He's one of the hospitalists at university and runs an excellent elective. It's called POCUS CDM, and a lot of this talk is based on what he teaches in that, which I found very helpful in my day-to-day clinical life. So today we're going to understand how to interpret a receiver operating characteristic curve, or ROC curve, and then incorporate those into our clinical decision making. And then we're gonna just use ROC as an example in terms of BNP and a ferritin example. So before we get started, as we always do, we have a primer. Today is ECG, unrelated to our talk, but please feel free to chat or unmute yourself and tell me what you see. Dr. Chen, one of our attendings, sees something.
Is that an epsilon wave?
Close, it's a different eponym. Osborne, yep. So Sam, one of our residents, mentions an Osborne wave. And Sam, where do you see that?
It's like after at the end of the QRS conference.
At the end of so this little spike that you're seeing, right? Yeah, you see it in V2, V3, and 4, 5, 6 here. You can also see them in 2, 3, so they're sort of everywhere. And Sam, tell us why you thought this was an Osborne wave and not an ST elevation.
With the morphology of having, you have your QR and almost like a little S wave there, and then second wave, as opposed to like your ST segment, it's flat, or it's like has the convex.
Yeah, awesome. So this just reminds us to remember what our QRS means, right? And there's very specific criteria for what is a Q wave, what is an R wave, and what is an S wave. So let's go through it. So here's the wave we're talking about, just to point that out. And then if you look between if you compare the PR to the ST, that's actually pretty uniform. And so we don't see any ST elevation or depression here. And then remember, a Q wave is the first negative deflection. An R wave is the first positive deflection. And then you have the negative deflection after an R is an S wave. And so some people may confuse this for, let's say, an R prime, but just recognizing that you have to fit this into a context, and that usually you don't see that morphology in 2, 3, and F. And so why did I bring this EKG today? Cold. Dr. Chen says it's cold. So remember that Osborne wave is commonly seen in patients who present with hypothermia, and with the weather changing and it being really cold, you may notice these in your patients if they come in hypothermic. Awesome. So I'm just going to present the case, and then we're going to set it aside and talk a little bit about how we're going to go through it. So today we talk about a 49-year-old man with coronary artery disease, hypertension, hypothyroidism, presenting with symptoms that may be concerning for heart failure, so dyspnea, edema, some chest discomfort. Their vital signs are actually pretty okay. They're on a little bit of oxygen, and then you note that the BMI is 38. On their x-ray, there's cardiomegaly and some vascular congestion. And so I'm hoping that, as we've talked about in our previous talks, that you guys are starting to develop a pre-test probability for what you think may be the diagnosis, right? And so I'm giving you information to feed into that. Then the troponin is 0.21 and the EKG has low voltage. But you notice that the BNP returns only at 40. And so we're going to talk through how we can use ROC curves to work through this discrepancy, where in some patient where you're suspecting they may have heart failure, but the BNP returns quite low. Okay, so the reason I wanted to talk about this today is because understanding ROC curves will help you make decisions in times of uncertainty. And while there are not many ROCs are there, or difficult to find, I think the future of medicine will go toward us utilizing ROC curves more to help make us decisions. So I wanted to bring up where ROC curves come from. So ROC curves are, the way the name ROC curves comes about is that in World War II, radar operators had to decide that when they saw blips on their radar, whether these were enemy targets, whether they were friendly ships or just noise. And their accuracy was determined by how well they were able to determine this. And their accuracy was called a receiver operating characteristic. So each operator had their own receiver operating characteristic. And so if we compare that then to medicine, right, we every day have to determine which tests we think are truly a true positive, a false negative, or a negative. And an ROC curve can help us make these determinations. So let's get into it. So before we talk about ROC curves, we have to understand how we derive them, right? So we have tons of tests we do every day on our patient. Every single test we do has been determined with a cutoff, right? And so you'll see a low end cutoff and a high end cutoff. So for any given test though, we decide the cutoff point. It's a subjective value. And how do we decide where the cutoff goes? Well, what we want to do is in a test, we want to put the cutoff point where there will be the least amount of overlap between the true negatives and the true positives, because we want to separate those curves as much as possible. And you can move that one way or the other, and you'll end up capturing more of one population or another. So let's see an example of this. Before we do that, I wanted to just talk about sensitivity and specificity. I think quite commonly we talk about these terms in math and in formulas, but I want you guys to think about them in terms of what they mean. And so sensitivity you can think of as the probability of a positive test given that the patient is ill. And specificity is the probability of a negative test given a patient is well. So you can't have both be really, really great. And so what that means is if you want to catch more patients that are positive, then that means you can't avoid having more false positives, right? Your test is going to be positive more often, but that means that you're going to have more false positives. So just keep these definitions in mind as we talk about how we derive ROC curves. So let's take, for example, T4 values. So in 1987, a couple of authors did an analysis on looking at T4 levels and at which level patients were euthyroid or hypothyroid. And so here's a graph of what they found, right? And that looks like the two little bumps that we saw before. And so they're trying to decide where should we put the cup point for a T4 value. So if we put the cup point at a T4 value of 5 or less, then in that group, most of the patients were hypothyroid. So as you can imagine, the lower your T4 goes, the more likely it is that you're hypothyroid. Above 5, you missed a lot of people. They were still hypothyroid, but majority of which were still euthyroid. So if you do the math here, you should be able to verify that sensitivity of this test is pretty poor, but specificity is awesome, right? Because most of the patients with 5 or less, we only lost 1 patient out of 100. Let's say we move the cut point to 7. In that case, you capture a few more people who have a positive test that also have the disease, right, which is sensitivity. Positive test given a patient is diseased. And so you capture a few more people because you moved your cut point higher. But that means that you are going to get a few more false positives, meaning that your specificity goes lower. Specificity, remember, is the probability of a negative test given that you are well. And so you're going to have a bunch more false positives. So they did the rest of the math, and if you chose a cut point of 9, what ended up happening was that your sensitivity got a lot better, but your specificity continued to get worse. And so with different cut points, you're gonna have different sensitivity and specificities and different probabilities of positive, true and false positives. This is gonna make more sense in just a second. So remember, this is to say that a test will behave in the way that it is designed, but that we can reinterpret the results using an ROC curve. So what does that mean? So doing a little more fancy math, all they did was subtracted the specificities out of 1 and got the false positive rates, and then charted these as points on the curve. And so this first point, right, is at cut point of 5, and so the false positive rate, which is this, is 0.1, so that's going to be really close to 0 here, and the true positive rate is 0.56, right? So that's where they've graphed this first point, and so they're just graphing these points and on the x and the y axis, and then connecting the dots basically. So the beauty of an ROC curve is that what we can do is use the slope of the tangent line at that cut point, which ends up being the likelihood ratio. And we've already talked about likelihood ratios and how they can help us make decisions and change our pre and post test probabilities. So in this graph, the likelihood ratio at a cut point that ends up in the high slope area is really high, much, much greater than 1. A cut point that's at this part of the curve has a likelihood ratio of 1, right? This tangent line has a slope of 1. And so therefore, a likelihood ratio in the flat part of the curve would be much, much less than 1, or technically negative. So how do we put this into practice? So for this patient, if we use a cutoff of less than 5, so T4 less than 5, you draw a tangent line, and the likelihood ratio here ends up being positive 52. So if a patient then has a T4 value of less than 5, you can say very confidently, and even if your pretest probability was only 5%, when you multiply that, or when you do the likelihood ratio of 52, with even a 5% pretest probability, your post-test probability is going to be in the 80s, 90s, right? So it's gonna increase that much higher. And so we can use these ROC curves to determine what the tangent line is, therefore what the likelihood ratio is, and what our post-test probability will end up being. And so let's go back to our case. Remember, this patient, we think clinically may have heart failure, but their BNP is 40, and so we're trying to reconcile that information, right? So I want you guys to take a moment and perhaps come up with a pretest probability that you think, whatever you think is that this patient has heart failure. So just some thoughts that I had when I present a case like this, or when I'm presented with a case like this. It's, wow, this patient's symptoms sound like heart failure. I've also heard that obese patients may have falsely low BNPs. And so how should I interpret this BNP of 40 in a patient with a BMI of 38? Is this still high in that patient? Is this low in that patient? Well, we can use an ROC that's been developed for BNP to answer this question for us. So here's that ROC curve that I'm presenting to you. This data was determined off of a study of about 1,300 patients. And what they did was they took patients with a BMI less than 25, in between, and then BMI greater than 35. And so if you look, the graph of BMI greater than 35 is this dotted line, right? And they're presenting to you different cut points on that line. So for a BNP of 400 or higher, so in this area of the line, you can imagine that any tangent you draw will have a very positive likelihood ratio. And so if an obese patient came with a BNP of greater than 400, you can be very confident that you can use that BNP and it will increase your likelihood that the patient has heart failure. So you can look, so 300 also a pretty good cut point. 200 and 100 are starting to come with slightly lower slopes. 200 is still pretty good. The 100 is essentially in that part of the graph where your likelihood ratio is 1. And so that won't really change your pretest probability in any one direction or another. They didn't give us any cut points lower than 100, but if we imagine that this point, let's say at the X, is a BNP of 40, and I've drawn a tangent line for you there, you can tell that this tangent line is pretty flat. I know that in this part of the curve, the LR is 1. That means that this LR is much less than 1. And so in this patient, your pre-test or your post-test probability that they have heart failure is now lower. So does that make sense what we did? Is in this patient, we were concerned that due to their clinical syndrome that they have heart failure, but this BNP is 40. Sometimes it can be falsely low in obese patients, but we can now infer that in this patient, the likelihood ratio actually with a BNP of 40 decreases our post-test probability. And so in this patient, it'd be worth your while to look for alternate etiologies. Okay, so let's do this for a different example. So we'll talk about iron deficiency anemia in the elderly. And so why is iron deficiency anemia in the elderly maybe different than younger patients? So we know that IDA in elderly patients is associated with decreased physical performance, increase in number of falls, frailty, poor cognition, increased dementia, increased hospitalizations, and increased mortality. And 11% of our elderly population has iron deficiency anemia. So it's not a small number. And so we should be catching more patients with iron deficiency anemia and treating it. So why are we talking about this? So there was a study that again did similar ROC analysis. And so they gathered a bunch of patients of inpatient and outpatient, and they actually checked this patient's ferritin levels and then compared it to the gold standard of a bone marrow biopsy. So all of these patients got a bone marrow biopsy to determine if they were truly iron deficient or not in comparison to their ferritin levels. And these are the cut points that they came up with on their ROC curve. And so for here, if you look, a ferritin of 18 or less is going to put you in that part of the curve that has a really steep line, which means a really high likelihood ratio. And then anything above 100 puts you in that pretty flat part of the line where your likelihood ratio is going to be negative or less than 1, right? And then somewhere in between here, you're going to end up with a likelihood ratio of 1, and so it won't sway you one way or the other. But remember that this part of the curve also has some normal ferritin values, but that may be low for an elderly patient. And so what they did was how in our T4 example, we took a bunch of cut points, we looked at the sensitivity and specificity, and worked our math that way. And here, they did some backwards math and came up with the likelihood ratios. And essentially what the authors are trying to say is if the ferritin is less than 18, then your likelihood ratio is 41 that the patient has iron deficiency anemia. And we're like, well, duh, 18 is really low. Of course they have iron deficiency anemia. But then any value in between 18 and 45 gets you a likelihood ratio of 3. So what I'm trying to say is between 3 and 41, there are a lot of likelihood ratio values that are not represented, right? And so think critically. Where does a value of say 35 falls, which may be in the normal reference range at your hospital, but 35 may be somewhere here on the ROC curve that still has a pretty steep curve, and that is still going to have a likelihood ratio that's much higher than 5, increasing your post-test probability that that patient has iron deficiency anemia, when you only look at ferritin level to determine that. And so I think this is to say that when you guys think about tests, just remember that cutoff points for tests are determined by us, by our body as physicians and lab and scientists. And in an optimal test, the true positives and true negatives would be completely separated, and that the overlap would be essentially null. In which case, the ROC curve is going to look like this, right? Super steep and then super flat, and there's going to be one cut point where the curve changes. And so I'm sure you guys have heard of area under the curve as often being referred to as ROC. And in this example, area under the curve will near 1 because this is a nearly perfect test. And in this type of test, you can look at the area under the curve and say, this is a fantastic test. I'm just going to make one cut point and go from there. But what often and commonly happens with all of our tests is something like this, a middle area, where the area under the curve is not going to be very helpful. You're going to have quite a bit of overlap, and we have to decide where to put the cut point. What ends up happening is that we still decide just one cut point. So for BNP, let's say, in your mind, you've decided, okay, my cutoff for BNP is 100. Anything above 100, I'm gonna say is gonna increase my likelihood for heart failure. Anything below 100, it's not heart failure, right? So we often have these singular cutoffs in our mind. And the argument is really that we should have multiple cutoffs in our mind. And that is to say that at this cutoff, anything below it is going to significantly raise your likelihood. Anything above this higher cut point is going to significantly reduce your likelihood ratio. And anything in between, you better think critically about where your patient fits in that. If there's an ROC curve that you can find for your specific patient population. So for example, for ferritin, they have ROC curves for patients with ESRD, for elderly patients, for women. And so they have a couple different ROC curves to which you can refer and figure out, well, is the singular cutoff that I have in my mind of 40 a good cutoff for the population that I'm treating, right? So BNP also changes with age. And so they have ROC cutoffs for BNP as relates to age. And so you're going to ask yourself, is my cutoff of 100 the same and give me the same likelihood ratio if I'm looking at that in a patient that's 35 versus in a patient that's 80? And so the argument here is that for really great tests, we can sure use one cutoff, but for most of our tests, we need to start coming up with different cutoffs and perhaps present our data like they did here. And so if you can imagine, for let's say we do this for procalcitonin, for which an ROC exists, or for white blood cell count, right? We can give ranges. So white blood cell count of 4 to 7 is a likelihood ratio of 1. So that's not going to tell you much. 7 to 9 is maybe 2. Not great. Okay, 9 to 13 is 5 or 7. And then 13 to 20 is 50, because anyone that has that high white count is very likely to have an infection or inflammation or whatever the context is in which you're looking at the patient. And so think about which tests you would like to see presented this way and which tests we're currently using with just one cut point, perhaps inappropriately. And then, you know, a test like this where there's a ton of overlap, we don't use because that has an area under the curve of half, and the test is useless. Okay. So just to say, start considering ROCs, using ROCs to help with your clinical decision making, especially when you may be confronted with your clinical judgment going one way, the test going another way, and whether that single cut point for that test is appropriate, and whether you should be doing a little more digging into seeing what data others have collected for that test, and what test characteristics exist that you may look at to see whether your decision can be swayed one way or another. So just to recap, today we talked about these receiver operating characteristics, remembering that sensitivity is really the probability of a positive test in a patient that's ill, and specificity is the probability of a negative test in a patient that's well. And then we talked about a BNP example in a patient that's obese, and then we talked about a ferritin example in our elderly patients. So we have a short conference today, but I wanted to see if you had any questions or comments about that, or if any of you have used ROC curves in your day-to-day life for clinical decision making, or if you have any other ways that you make your clinical decisions that may be even better than this.
That was really good.